So coming to the next module, what are difficult scenarios? Nobody answered me that. We were starting with that. Yes, besides breaking, okay, to save time, of course bad news, adverse outcomes, and if the patient is a child who is suffering, that becomes horribly bad. And what happens to us? How do you feel when you are going to break the bad news or see that happening in front of you? How do you feel?
Sad.
Very sad. I feel a lump coming in my throat and everything kind of going ripping apart inside me. If it's a child, I start seeing face of my child in it if it's the same age group. All silly things come. So what happens here? Emotional arrest kind of situation. And what to do? I help myself by assist myself by using the assist model, which is acknowledge it, accept it first of all. Then say sorry, not because you have done something wrong. Say sorry what the patient's relative are feeling or the patient is feeling. Say sorry for that. You are not liable, you are not accepting anything, you are just a human to human sorry, which we all say to each other. I think I've said 10 times sorry since I started the lecture for many reasons. I should not be. The night game, it was not my fault, I can defend that. But I said sorry because you were all kind of inconvenienced. For your inconvenience, I said sorry. What's wrong about it? Nothing. That does not mean that the electricity went because it was my fault. Similarly, if you say sorry to your patient, it's not because you are saying it for your fault. You are saying because it's a situation, a problem, a kind of feeling one is going through and you're feeling bad about it as much as you can and you are expressing it. So learn to say sorry, very important, helps a lot. Then try to discuss the story in a given context to get more knowledge, to get the feel of emotions what's going through, because that's what you want to know and to try to help out. And then you inquire more into it to find out solutions. When you inquire, the patient also has a self-reflection. He will come out with some solutions by some of your questions and you will find some solutions as well. So you find a solution by inquiring further and help it out, and then you do not abandon the patient after that. You travel with them. You say that you will come back to them if there is any information still to be given. You will come give them a future plan to meet up, or if you are referring it to someone else, then you say that you will follow up further as well, or you come back on phone and talk to them later about something. So do not leave them alone. But of course, if you forget assess model, you can remember RAB, which recognize and acknowledge is the same part. Verbalizing is the rest of the bit, which is also the idea. Now coming to handling difficult colleagues, and I'm sure that must be a common problem here as well, because that's a problem in every hospital. Coming to a story first, real life. 1998, second year DNB training, finds lots of problems going on in the patient care with evidence over 3 months period after his joining, and he communicates to the responsible staff who stays maximum with the patient. And who is that? Our nurses. They stay maximum with the patient. So he's realizing there are errors being committed and he starts talking about it. And loads of complaints get generated against the doctor and the management decides to throw him off. But for the good consultants who say that professionally, technically found doctor very strong, he talks nice to the patient. So doctor is given a choice that you will not tell anything to the nurses if you find something wrong, but just call the matron and that's it, and we will handle it from that point. Doctor was very relieved, very happy, but the nurses were in further trouble who were making errors. But was that the right solution? For patient safety, security was good. The nurses' complaint obviously went to zero because there was nothing to complain because doctor stopped saying anything to them. And the patients were obviously safe because doctor was taking the right step. But there was a kind of friction which has come up because the matron was after the nurses now. And nurses can't do anything except to curse that doctor. But what would have been the best choice? Because the problem was doctor's way of communicating to the nurses. He did not know how nurses think, how they work. But admits and agrees that nurses spends more time. They do lot of work which doctors can't even think and imagine, and they are very vital for the patient care. And they are more humanistic than even doctors are. That's why the nurses exist. And that's how they evolve. So Understanding of that was needed and a course was needed or some guidance was needed, which unfortunately did not exist at that time, but that exists now, and I'll discuss that further as well. How to communicate nicely with your colleagues, be it doctors or nurses. But why it is important? Why shall I do it? Because the lives of patients, of our families, of our friends depends on that. And if we falter in it, do not do it appropriately, it can lead to criminal convictions as well, leading to loss of license, which has happened with a cardiologist in this city. I'm not aware of the name, but some of you maybe, has been rolled off the MCI. And the issue was communication. As Dr. Visam told me, Board of Governors, MCI. And I also want to add, communication is the issue 100%, as Dr. Visam told me after analyzing the data which has recently been done at MCI. I don't have it in writing, so I'm saying what verbally has been told to me at Max Hospital yesterday by Dr. Visam, or in the public forum like this. To give you an example, an elderly patient came to emergency department with necrotizing fasciitis of his leg. Doctor brings a complaint that she has overheard doctors from various specialties arguing over who would take responsibility. There was a delay in admitting the man who, despite surgery, died from his condition. The daughter brought a claim for negligence, citing disputes and consequent delays as contributing factors in her father's death. Now I'll ask you a question. This case goes to the court, and this case has happened, consider it has happened in this hospital. Okay, you know your hospital better, technically and whatever. You work here. What are the chances, if I give you three choices, I'm giving you a close question. What are the percentage-wise chances that hospital and the doctors will win the case? 30%, 50%, 90%. How many people say 30%? Please raise hands. 1, 2. How many people think it will be 90%? Please raise hands. Only 1. How many people think it will be 50 to 60% hospital will win the case? Most of the people have not raised hands. You are tired? Okay. Okay. Let's see what Dr. Kilke wants.
In the council, when it comes for an inquiry, and I've been in the council for the last 10 years, if the patient can prove that this happened, the doctors will be convicted. Absolutely. It all depends upon the proof. If they can bring one proof from anywhere that this happened, and because there is an MCI clause is very clear, the patient must not be neglected. So if they can say that the doctor did not care in any way, then hospital will not win. If hospital win, it will be through other ways, not on merit.
I'll explain it now other way around. When I asked this question at AIMS and all the other hospitals, the AIMS people said 90% chance is we will win the case. That was an overwhelming majority there. And I'm pretty sure even in this hospital, 90% chance is Moonshine will win the case if it happens. Why? Because technically there is nothing wrong I can see prima facie in these statements, and that's what happens actually. Because technically this is a norm, this is how we operate. Nowhere it is mentioned that treatment was delayed. Everything was given. Of course, the patient was shifted later at a late stage, but that's what happens, that's what's normal, especially in the government sector set up on further on the top, and that's a norm. But the treatment was not delayed. We don't discuss, but what happened actually, what was wrong? The communication was issue. The relative was overhearing things which doctors were talking in public spaces, and a lot of miscommunication did happen, misunderstanding did happen. So there's only 5 to 10% chance the patient or relatives will win. Yeah, sure.
See, we require three things when we are dealing with the case of negligence. So in the first thing is that you have to show there was a duty. So there was a duty, every doctor agrees there was a duty. The second is there was a breach of duty. Yes, you can see there was a breach of duty. And the third thing is there has to be a damage. In this case, the patient died. So there is a breach of duty and the patient died. Now it will be on the part of the doctors to show that this breach of duty was not responsible for the death, then only they will win, otherwise.
Exactly. I fully acknowledge, appreciate and agree with what Dr. K. Chabra has said. And if the doctors will be able to prove that technically things were correct, which does happen to be correct most of the times, the doctors in the case. Says who? The data I have got from Mumbai city, the insurance people, I know them personally, and when I was in Mumbai, they shared with me 300 cases came last year, 95% went in the favor of the doctor, and 5% were against them. That's Mumbai city. So that's what happens. Of course, if technically there is an error, we will get sued and will pay the damages. So the problem happens when we refer the patient. This is one mnemonic which can help a lot of people if they are finding difficulty in referring their patient. More especially if it's a government hospital. Talk about the situation, speak about the background, see what you have assessed and the investigation and treatment given, and then generate the response from the doctor you are referring to. You can tell them that this is a case of appendicitis and hence take it, and he will take it. Or if you are not sure what you are dealing with, like happens in abdomen, we don't know it's a medical or surgical thing, but given whatever you have, and you say you don't know, I don't know, I'm feeling out of depth what exactly I'm dealing with. Will you be okay now to please take the patient and help me out? He will not say no, because he has no choice. You are told, you raised hands already. So that's the response or the reaction you can manage to get. And 99% of the times your referral will move over. Coming to the tips for good communication, if somebody is asking you too many questions, how do you feel in your day-to-day life? Yeah, but how do you feel if somebody is asking you too many questions? Sorry? Irritation? Am I right? That's how it is exactly. Even everybody does. Even it's a common thing I hear everywhere. And I feel the same at times. I must admit that. But tell me one thing. How many people you think who have irritated you by asking too many questions in your personal life or otherwise have been diagnosed to have something problem with their mental faculties? Could you recall one case? No? So there are many people who get irritated when they are talking to us, but we are finding it difficult to remember that they were having some mental problem. So there may be, I don't deny that, some dementia maybe and all, we may get irritated, but actually we laugh with them because we know that. In a genuine case, we laugh with them because they have a problem and we can see that. But with a normal person who's asking so many questions, we get irritated. Or should we? That is the question. Why? Because that person, if you are able to look into his mind, lots of questions, worries and concerns, and that's why these questions are coming. He's asking for help and he's looking to us and we are not doing it actually. So how can you assess yourself how good you are at communication and approachability and openness? You can do a 360-degree appraisal that will reflect in an anonymized manner from your colleagues, from the people you work around with, and that can help. And that's very easy, and I'm more than happy to help if somebody wants to generate at the system hospital level. Of course, do not forget that do not have difficult or sensitive discussions in the open spaces. Otherwise, also remember to document instructions to colleagues in a proper manner in clinical records, and if it's oral, make sure that it's been carried out properly. Regarding consultants, ensure that your instructions have been understood correctly by juniors by making them echo what you have said, or if you are in a bit of rush, summarize the key points again in the end before saying bye. And also make sure you encourage questions out of them because they are taking care of your patients and you are rushing off, something is going to go amiss and responsibility is entirely yours, not of your juniors. You know that. It's your patient at the end of the day because you are the consultant. Of course, review the notes to avoid misunderstandings of any instructions given from time to time. Make sure you have robust protocols, which I'm sure you have for junior doctors as well as nurses at changeover of shifts and also when patients are admitted or at the time of discharge. One can do clinical audits to see how these measures are working appropriately and effectively. Do not email or put on Facebook criticism about your colleagues. And if nothing is working out, find out what your hospital procedure and protocols are and raise the issues in factual, accurate, verifiable and non-judgmental manner because the issue has to be dealt with. But never ever say, be it your personal communication or with your patient or even with a violent patient, calm down, never say that. Don't say, what do you want me to do about it? Don't say, I'm not going to say this again. Like I just said before and I apologize for it. When you asked for the 8 to 12 minutes, as I said that, I should have not said that. Okay? Don't say these are the rules. Patients don't understand rules, your protocols. We start showing them the protocol. This is a guideline from XYZ, Don't show them. They don't understand. They don't care. They're not here for that. Don't say be reasonable. You are insulting the other person by saying that. Don't say what's your problem, and never ever say I can imagine how you are feeling. If somebody has died in somebody's family, his father or something, and you will start recollecting when your father died, how you felt, and you will say automatically, I can imagine how you are feeling, because you are thinking of your experience then. And that's what makes you say that. But do you think is that correct? I say no. Why? Because his permutation combination is different. Yours was different. He has got different liabilities. He may be having loans. He may be having some family issues. He may be having childhood problems or a very happy childhood, which may be entirely different from you. You can't think how is he feeling. How can you imagine how he's feeling? So who gives us the right to say, I can imagine how you're feeling? Nobody. We give this right to ourselves, and we are wrong if we are doing it. Because we can't imagine how is that person feeling. So what can you say then? You can say, I can't imagine how you feel. And that will generate respect from the patient as well. We will like you for that. How does communication breaks down? 55% your face, what expressions you are giving, your tone of voice, 38% chance. And the actual context, the technical bit which we love to talk about amongst ourselves and to our patient, has only value of 7%. So, in other way around, if you are 93% wrong in your technical language or the real context and the crux issue, but your facial expression and voice or tone voice is good, you will can get away 93% of the time by giving wrong information as well. Power of communication. At this point, I will break here and see any more questions if there are.
Sir, in emergencies or critical cases and even in practice we see and patient or attendant say, can you save this patient, then we are ready to bear all the expenses. If you cannot save the patient, then it's better we can save our money. So in that case, how we should handle those patients in emergencies and as well as in OPD practices. Thank you, sir.
Before I answer, what do you think is the answer? As per you. As I said, I will ask patient what is their solution. That's why I'm asking you, what do you think is the solution? Probably your solution is better than mine. Or it could be not, but still.
Attendant is looking for the life of the person.
No, I'm asking, what do you think, what do you say? If somebody comes to you, how do you answer this question?
We'll try our best to save the life of the patient.
That's all you say. Or do you say something more than that? Or anybody wants to help? I want to see how audience gives answers. That's the purpose we are doing. Anybody wants to answer that? How you should deal with that situation? Anybody? Okay, then I'll answer. How will you also say?
I will definitely add to that what are my chances, what are the chances. If I can tell him that this condition is, say for example, it's a situation where DNR is there and we don't have in India the DNR rules. And if I know that he is not going to survive, my answer may be different. But if I know that there are chances, I will say that let's try it out.
I'm an emergency doctor, by the way. I'll tell you how I handle, be it India or anywhere. And I was here 1.5 years back, and I used to face the situation max emergency as well. People used to come there as well like that. Because if a major accident happens, people used to end up there as well. If this question comes to me, I'll take a pause, first of all. I know there's a problem, and it's a massive problem. And every word I'm going to speak is going to retain and can get used against me as well. And I have to be in bigger trouble as well. So I have to be technically as well as emotionally very correct. And I have to do my duty as well. I'm very conscious about it. So what will I say? I'll say, okay, you asked me this question. I need 5 minutes to answer that question. Let me go inside, see the patient again. Let me get all the information. 5 to 7 minutes is the range I need from you. And I'll speak to my team and colleagues as well. And I will give you a reply after that. Is that okay with you? What do you think the patient will reply? Okay? I've told him very nicely. And he understands my limitations. So first of all, I'll share my limitation. Because I was not prepared for this question. Now then I will go back inside. I will see all the things, gather all the information. I speak to all my colleagues, see what they are saying, and I'm able to make a judgment out of it. And now the patient will fall in three categories. He is 90% chance of recovery if we give a good heart push. There is a 50% chance of recovery, plus minus whatever, if we give a heart push. There is only 10% of chance of recovery, whatever we do. So I will frame my answer according to that, that this is what it is, these are the reasons for it. Break it into small chunks, which I was not doing earlier, but now I will do that also, and see what they respond. Because at the end of the day, money is being spent by them. And having said that, I will explore their financial situation, and I will also see if we can do something about it. And I will share with them that if they are happy, I can speak to social worker if we can provide some money from our end, because we have that department in every corporate hospital, and that's what it's meant for. So he will feel empowered, he will not feel cheated, he will see the human side of it and the technical action of it. And that according to the response and the situation, we will become more situationally competent and become a team and do something about it. Does that answer your question?
Thank you, sir.